Good morning, everybody. Imagine a three-year-old child present with a history of acute onset of weakness affecting lower limb, and over a period of 2 days the child is completely bedridden. When you examine, the child is in excruciating pain. The power in lower limb is 2/5. The power in upper limb is 2/5. The reflexes are absent. There is a difficulty in swallowing and gag is weak. So how do you approach this case? So good morning friends, my name is Dr. Sunil Sable. I am a pediatric neurologist and associate professor in Department of Pediatrics. So today we are going to discuss about acute flaccid paralysis. So what do you mean by acute flaccid paralysis? Acute means sudden onset of weakness. It may be over a period of few hours or few days. Okay. So flaccid means there is hypotonia, absent reflexes, and there is no signs of upper motor neuron disease like hyperreflexia or spasticity. And paralysis means weakness. So this is the meaning of acute flaccid paralysis. Now the acute flaccid paralysis is very important as far as community is concerned, because this surveillance has been started to pick the case of polio and to take certain action so that the spread of polio is not spread across the community. So that's why this acute flaccid paralysis surveillance has been started. So acute flaccid paralysis means sudden onset of paralysis in a child less than 15 years or any age where the polio is suspected. So this is for community purpose. So we have seen what is the meaning of flaccid. Now the acute flaccid paralysis is not a disease. Okay, it's a clinical syndrome and it has a lot of causes. The importance of diagnosing a case of acute flaccid paralysis is, first we know that we have to rule out polio, and second thing for the patient purpose, because the cases of acute flaccid paralysis may become fulminant, means the weakness may progress over a period of few hours or days, and it may affect the respiratory muscle, and the baby may require ventilatory support. So we have to keep a watch on these patients. As far as polio is concerned, any case of acute flaccid paralysis has to be reported to the AAP surveillance officer. The team comes, they investigate the patient, and they collect a stool sample. They collect 2 stool sample. The size of stool sample should be 8 to 10 grams. It's like a size of a thumb, and it has to be collected 24 hours apart. So these samples are sent to virology lab to see whether there is any virus is there or not. Now you can see the anatomy of the spinal cord and lower motor neuron tract. So you can see if there is a sensation or there is any pain, the sensation goes to the sensory neuron to dorsal root ganglion, and it enters into the spinal cord. Then there is an interneuron, it sends signals to the anti-horn cell, and from anti-horn cell there is a ventral root. Okay, there is a ventral root, and there is a motor neuron, it supplies the muscle, and there is a effect. Okay, so this is a low motor neuron arc, and if there is a problem in any part, then it leads to acute flaccid paralysis. So what are the causes of acute flaccid paralysis? So we have seen the anatomy. The spinal cord affection may cause acute flaccid paralysis in acute stage. So it may be because of trauma, because of transversemyelitis, if there is any infection like epidural abscess or hematoma, it may cause injury to the spinal cord and it lead to acute flaccid paralysis in acute stage. Okay. Then there is a affection of anterior horn cell. So this may occur in poliomyelitis, vaccine-associated polio, or other non-polio enterovirus like type 71, or Japanese encephalitis, or anterior spinal artery infarction. Now, if roots are affected, then it also leads to acute flaccid paralysis. For example, in case of Ghia syndrome, post-diphtheric polyneuropathy, porphyria, rabies, and injection-related sciatic neuritis. Now, neuromuscular junction like myasthenia gravis, organophosphate poisoning, snake venomation, drug like aminoglycosides, botulinum toxins, hypermagnesemia. Or if there is a muscle affection like myositis, poliomyositis, hypokalemic periodic paralysis, and hypokalemia. Now we will see one by one briefly how we approach a case of acute flaccid paralysis. Now poliomyelitis is now a history as far as India is concerned, but still we have to keep the eyes open and surveillance system intact so that you can detect the poliovirus infection as early as possible. So usually the polio is to present with the history of a fever, headache, vomiting, then there is a neck stiffness, tripod sign, weakness which is asymmetric, proximal more than distal, pure motor weakness, and it is residual, means there is no recovery. So this is a typical presentation of poliomyelitis. As far as India is concerned, in March 27, 2014, India has been officially declared as a polio free. Now in this figure you can see the baby is having this tripod sign. You can see this is a tripod which is formed. So this is very classical of poliomyelitis, and you can see the residual weakness after the infection. So this is typical case of poliomyelitis. Now there is other virus other than the polio, like non-polio enterovirus, which may affect anterior horn cells and lead to AFP. Now transverse myelitis. We know the spinal cord in an acute stage may cause acute flaccid paralysis. So transverse myelitis is usually a demyelinating disorder. Okay, so it affects the spinal cord. There may be a history of prior infection, or there is vaccination, and it may lead to the formation of antibodies which cross-react with the myelin of spinal cord. So it may occur as the isolated syndrome, which is called as clinical isolated syndrome, or it may be a part and parcel of other disease like neuromyelitis optica, in which there is affection of optic nerve and other part of brain, or multiple sclerosis. So transverse myelitis has to be kept in mind in a patient with acute flaccid paralysis, because in an acute stage there would be hypotonia, absent reflexes, and later on after a few weeks there would be the signs of upper motor neuron like hyperreflexia and spasticity. The important thing we have to remember that whenever there is affection of spinal cord, it leads to the affection of bowel and bladder. There may be the incontinence, or there may be urinary retention. So this sign has to be kept in mind. Second thing, there is a sensory loss or sensory level. At the level of spinal injury or spinal affection, there would be sensory level. So we have to keep this in mind, and MRI is very important to diagnose a case of transverse myelitis. So MRI spine has to be done, and treatment is usually steroid. Now in this figure you can see here, this is a pons, this is medulla, this is cervicomedullary junction, and the spinal cord starts from here. So you can see this is a normal spine cord, and you can see this whitish demyelination, whole spinal cord has been demyelinated. Okay, so this is transverse myelitis. Here also you can see the cervical spinal cord is white, so there is a demyelination. So this is a T2 weighted MRI spine which is showing hyperintensity in the cervical spinal cord. So it's a transverse myelitis. The next cause is a Ghia syndrome. So Guillain-Barré syndrome is acute autoimmune post-infectious polyradicular neuropathy. It is a very common cause of acute flaccid paralysis. The most common cases of acute flaccid paralysis are that of GBS. So we will discuss this GBS in a detail. So first case of GBS has been described in 1960 by Ghia and Stroll in a patient. They had two patients where there was an acute onset of weakness and their CSF was showing no cells but it increased protein. So it is called as albuminocytological dissociation. So this is a Ghia and Barre. Now as far as epidemiology is concerned, the incidence is constant across the world. The 1 to 4 per 1 lakh cases annually. There is slightly higher incidence in men as compared to women. The ratio being 1.5:1. And treating Guillain-Barré syndrome is very costly affair. In United States, because everything is documented there, so it requires almost $1.1 lakh to treat a case of Guillain-Barré syndrome and $3.6 lakh as a lost productivity. So there has been no direct cause found as far as GBS is concerned, but in 2/3 of cases there is either upper respiratory tract or lower respiratory tract viral infection preceded by the onset of GBS. And the virus which are implicated are C. jejuni, cytomegalovirus, Epstein-Barr, mycoplasma, Haemophilus influenza, influenza, parainfluenza, and HIV virus. Sometimes the vaccine may be associated with a case of GBS, but it's very rare. Now, why this GBS occur? So they have found that it is a post-infectious immune-mediated disorder. For example, cellular and humoral immunity takes part into it. Now you can see this is a proper structure of neuron. You can see this is a cell body, this is a nucleus, this is the axon, and there is a myelin which covers the axon. Now what happens, this is a C. jejuni bacteria. Okay, so it has a lipopolysaccharide on its body. So when it enters in our body, the body forms antibody against this lipopolysaccharide. Okay, but unfortunately what happens, this lipopolysaccharide is very similar to glycolipid and ganglioside which is present on the myelin sheath on neuron. So what happens, this antibody destroy this lipopolysaccharide of the bacteria as well as or virus, or it destroy the gangliolipid and gangliosides of the neuron, and it leads to damage to the neuron. So this is called as molecular mimicry because they have a similar structure. So the antibody cannot differentiate why differentiate, and it attacks its own organ. Now you can see this is axon, this is myelin of normal now, but after the damage you can see how the myelin is destructed. So there has been lot of antibodies which has been formed in the body of a patient with GBS, like LM1, GM1, and so many antibodies are there. So we will not go into detail. Now how these patients with GBS usually presents. So these patients usually present with acute onset of flaccid weakness, ascending weakness. Initially lower limb is affected, then upper limb, then sometimes the oropharyngeal muscles are affected, respiratory muscles are affected, and it may progress to respiratory failure as well. The weakness are usually symmetrical, proximal or distal, and course is monophasic, means it progresses, then there is a plateau and there is a recovery. Now the interval between the onset and the nadir of symptoms may be few hours to 28 days. The maximum is 28 days. It progresses over a period of few hours to 28 days, and then plateau, and then clinical recovery occurs. Most of the patients, almost 90% of the patients may have sensory symptoms like tingling, numbness, pain, and this is very important finding in case of a GBS. Mind you, 10% of the patients with GBS may have normal reflex or exaggerated reflex. So normal or exaggerated reflex may not rule out GBS. Cranial nerve affection occur in 45 to 75% of the patients, except 1, 2nd and 8 nerve, all the nerves may affect. So they may have facial weakness, then they may have a dysarthria, dysphagia, nasal twang, diplopia, ophthalmoplegia and pupillary disturbances. Sensory changes, we have seen that 90% of the patients have sensory symptoms like a tingling, numbness, pain. Usually the paresthesia starts at the tip of toes and finger and progress proximally, and they are restricted to wrist and the ankle. Okay. There may be loss of vibration, proprioception, touch and pain distally. There is an excruciating pain present in 90% of the patients. It may be because of direct nerve injury or paralysis or immobilization. Few patients may have autonomic changes because of affection of sympathetic and parasympathetic system. So they may have bradycardia, tachycardia, heart block, they may have a hypotension, postural hypotension, hypertension, anhidrosis, diaphoresis. There may be affection of urinary sphincter leading to urinary retention or incontinence, constipation. Respiratory involvement occur in 40% of the patient. Okay, so the signs being there is a dyspnea on exertion, there is a shortness of breath, there is difficulty in swallowing, slurred speech, and they may require ventilatory support in 1/3 of the patients. Now the GBS is classified on the basis of topography, which parts of the body is affected. The classical GBS, the affection is 4 limbs are affected. Now there are certain local form like a pharyngeocervical brachial. So we have affection of oropharyngeal muscles, then there is a cervical and there is upper limb involvement. There may be only weakness of the oropharyngeal muscle. So this is a bulbar type of GBS. There may be only affection of lower limb, then it is called as paraparetic GBS. Or there may be only facial nerve affection. So it is a bifacial weakness with paresthesia. Now there is other form of GBS which is also called as descending form of GBS. Means the weakness starts from the upper part of the body and goes downward, and the syndrome is Miller-Fisher variant of GBS. So the classical Miller-Fisher variant has acute onset of weakness, external ophthalmoplegia and ataxia. So triad of oriflexia, ataxia and external ophthalmoplegia. But there may be other local form of Miller-Fisher variant, means there may be only ophthalmoplegia and no other symptoms, or there may be only neuropathy, or there may be only ataxia, or there may be only ptosis or only mydriasis, or if there is affection of sensorium, then it is also called as bicustal brainstem encephalitis. So this Miller-Fisher variant of GBS are usually because of an anti-GQB1 antibodies. So just remember that these antibodies are usually present in extraocular muscles, and these are present in the spinal spindle and the reticular activating system. So that's why there is a involvement of extraocular muscle, affection of sensorium because of the affection of reticular activating system. Now there is a second way how to classify the GBS, and it is on electrophysiological classification. So we do nerve conduction study and electromyography in the patients of acute flaccid paralysis, and depending upon that we can classify them as a demyelinating and axonal. So demyelinating means it affects the myelin sheath, and axonal means it affects the axon. So demyelinating is called as AIDP, so acute inflammatory demyelinating polyneuropathy, and axonal are subdivided into AMAN and ASMAN. AMAN means acute motor axonal neuropathy, and ASMAN is acute sensory motor axonal neuropathy. So demyelinating and axon, depending upon which part of the neuron is affected. Now Miller-Fisher variant, pharyngeocervical brachial weakness and paraparetic GBS are axonal form of neuropathy, while bifacial weakness with paresthesia is demyelinating. Now we have to keep watch, because there may be other differential other than GBS in a case of acute flaccid paralysis. So there are certain features, if these are present, then you should the antenna should be raised, that there may be something other things which is other than the GBS. So what are these symptoms? This may be bladder bowel dysfunction at the onset, means it may indicate spinal cord involvement. Fever at an onset, so it may be some infectious causes, maybe some enterovirus or poliovirus. Sharp sensory level, so it may occur in spinal cord involvement. Slow progression with limited weakness without respiratory involvement, so it may be CIDP, it's called as chronic inflammatory demyelinating polyneuropathy. Marked persistent asymmetry of weakness, okay, so it may affect in any virus which affect the anti-horn cell, like poliovirus or non-polio enterovirus. Persistent bladder or bowel dysfunctions which occur in case of spinal cord involvement, or if CSF has more than 50 cells, then there may be some viral affection, or polymorphonuclear cells in CSF. So these things if present, so you should the antenna should be raised, and it may have other differential diagnosis. Now, whether the GBS is a peripheral nervous system or central nervous system, so in 10% of the patients we have discussed that there may be elevated, means exaggerated reflex or normal reflex. So most cases of Miller-Fisher variant and Bickerstaff brainstem encephalitis, we have a signs of apomotor neuron as well, because we have seen that the anti-GQB antibody may be present in reticular activating system, leading to altered sensorium. So it is postulated that the brisk reflexes is because of the affection of inhibitory interneuron which is present in the spinal cord. So the inhibition on the anterior horn cells are vanished, and they lead to exaggerated reflex. So how to diagnose? Now we have to understand the fact that each and every patient is a new patient. Each and every patient put a new questions, and it has to be approached in an individualized manner. You cannot have a preset answer to each and every patient. On a lighter note, we all know that when we appear for exam, Viva exam basically, so we are so confused and we are so stressed that we do not know what examiner is asking and what we are talking. So एक बार क्या होता है कि एक एग्जाम चल रहा है, तो स्टूडेंट एग्जामिनर के पास जाता है, एग्जामिनर उसको पूछता है क्वेश्चंस कि भारत के पंतप्रधान का नाम बताओ, तो स्टूडेंट बोलता है कि विश्व प्रसिद्ध माननीय श्री नरेंद्र भाई मोदी। वो बोलता है कि भारत को कब स्वतंत्रता मिली, तो वो बोलता है कि वैसे तो संघर्ष की शुरुआत 1857 में हुई, लेकिन बड़ी मेहनत और मशक्क़त के बाद 15 अगस्त 1947 को भारत को स्वतंत्रता मिली। बोले वेरी गुड। बोले मार्स में पानी है क्या, तो स्टूडेंट बोलता है कि साइंटिस्ट ने खोज के निकाला है, जस्ट डिक्लेयर करना बाकी है। तो इसका वाइवा खत्म होता है, जस्ट बाहर आता है, तो वी ऑल नो, तो सब स्टूडेंट्स उसको घेराव करते हैं और पूछते हैं क्या क्या है क्वेश्चंस, क्या पूछे क्या। तो जो इमीडिएटली नेक्स्ट जिसका एग्जाम है वाइवा है, तो वो उसको पूछता है कि यार मेरे को सिर्फ आंसर बता, मेरे को क्वेश्चन मत बता। तो वो स्टूडेंट बोलता है यार तू क्वेश्चन तो पूछ, वाला नहीं, मेरे को ऐसे पे आंसर बता। तो वो बोलता है, तो दिस सेकेंड स्टूडेंट ही लिसन द आंसर एंड एंटर्स इनटू द वाइवा। तो एग्जामिनर उसको पूछते हैं, ये तो बहुत कंफ्यूज्ड है, प्रिपेयर नहीं किया एग्जाम के लिए। तो एग्जामिनर उसको पूछते हैं कि तेरा नाम बता, तो इसने रटाया है, बोलता है कि विश्व प्रसिद्ध माननीय श्री नरेंद्र भाई मोदी। एग्जामिनर बोलते हैं अरे क्या है, बोले तेरा जन्म कब हुआ, तो वो बोलता है कि वैसे तो संघर्ष की शुरुआत 1857 में हुई, लेकिन बड़ी मेहनत के बाद 15 अगस्त 1947 को मेरा जन्म हुआ। एग्जामिनर बोलते हैं तू पागल तो नहीं है, बोलता है साइंटिस्ट ने प्रूव किया, ऐसे डिक्लेयर करना बाकी। ओके, सो ईच एंड एवरी केस put forward a different questions, and if you have a preset answer then you will misdiagnose it. So you have to examine each and every patient in detail and take the help of the test to come to the diagnosis. Don't have a preset answer. Okay, so we'll see how to diagnose a patient with acute flaccid paralysis. Now the diagnosis is clinically, and the investigation help in coming to the diagnosis, because what happens, the nerve conduction study and CSF analysis is usually normal in the first week of GBS, and we have to take a decision of taking as far as management is concerned in the first week. So it has to be on a clinical basis. So we'll see what changes occur in GBS. So we have seen that first week it may be normal, and from second week there is a albuminous-cytological dissociation, and at the end of second week 90% of the patient of GBS has albuminous-cytological dissociation. So what do you mean by albuminous-cytological dissociation? Means there is elevated albumin but there is no elevation of cells. So there is a dissociation between these two, and the cell should be less than 10, and this should be mononuclear cell. Now second test for the diagnosis is nerve conduction study. Now what happens, you study a nerve, you stimulate the nerve at two spots, maybe median nerve at wrist and at elbow. Wrist is called as distal and elbow is called as proximal. Okay, and you put the recording electrode on the muscle, and you record the activity from the muscle, and you stimulate the nerve at two spot. So when you stimulate, then you can see a C map. It is called as compound motor action potential. So you can see this is a compound motor action potential. So this is distally when you stimulate at wrist, or in lower limb at ankle, and here proximal in upper limb at elbow and lower limb popliteal fossa. So this is the compound motor action potential proximally, this is distally. Now you have to see when you stimulate and when there is a first deflection, it is called as latency. Okay, and this is called as amplitude, and this is the duration of the wave. Okay, so how to calculate the velocity? It is by formula distance divided by proximal latency minus distal latency, and then you will get the nerve conduction velocity. Now in GBS, in demyelinating form, you just remember the fact that there would be the prolongation of distal latency and there is a decrease in conduction velocity, and there is an absent or delayed H reflex and F wave. So these things you should remember. And in axonal variety, the conduction velocity would be normal but the amplitude will reduce. So axonal A, amplitude. Okay, so axonal amplitude will reduce, and in demyelinating the conduction velocity and latency will reduce, because myelin is very essential for the conduction of the nerve impulse. So the velocity will reduce if there is affection of myelin. So you can see here, this is a distal compound motor action potential, and this is proximal. So this is a normal. Okay, and here you can see in demyelination there is a increase in distal latency. You can see the normal latency is this much, and demyelinating it is prolonged. Okay, so and in axonal you can see the amplitude, and in axonal you can see the amplitude is reduced. Okay, so just remember, demyelinating there is a prolonged distal latency. If latency is prolonged, then velocity will also reduce, and in axonal there is decrease in amplitude. Second thing is magnetic resonance imaging, because we know that in first week the nerve conduction velocity and CSF may be normal. So we can do MRI spine and with contrast, and there would be root enhancement, and this is occur in 90% of the patients of GBS, especially at the quada equina. You can see here there is an enhancement of nerve root. Here there is an enhancement of nerve root after gadolinium dye. So again it is showing spine enhancement. Now treatment, as far as treatment is concerned, usually the patient has to be admitted because they has a rapid progression of weakness, may affect respiratory muscle, may require intubation and ventilation. So you have to admit, you have to monitor. Okay, then if the patient is unambulatory, means he is not able to walk, then the treatment of choice is immune modulatory therapy, either IVIG or plasmapheresis. So these are the two specific treatment, and supportive means respiratory therapy, cardiac monitoring, nutrition, and you have to take care of the infection. So monitoring is very essential. So we have to monitor the respiratory system, because this patient may have either oropharyngeal weakness, lot of secretion going into aspiration, pneumonia, or they may have a affection of respiratory muscle leading to respiratory failure. So what are the signs which tell you that these patients may go into respiratory failure? Means we have seen that dyspnea on exertion, use of accessory muscle of respiration, if they are not able to lift their head from the pillow, they are not able to abduct the hand, or there is a decrease in breath counts, okay, in one breath, and there is a use of accessory muscles, so seesaw respiration and tachycardia. So this may give a clue that this patient is going into respiratory failures. Then you have to intubate this patient. Cardiac monitoring is very essential, because we have seen that because of autonomic involvement, this patient may have bradycardia, tachycardia, there may be hypertension, hypotension, heart block, so we have to monitor cardiac wise. Nutrition is very important, because these patients are hospitalized for weeks and months and they are not able to swallow, so either you have to give enteral or parenteral nutrition. Prevention of infection is very important, as when the patient is bedridden and they are intubated, then chances of infection is quite high. So we have to take care of infection by having minimal sedation, frequent physiotherapy and mechanical ventilation. Prevention of bed sores by frequent changing in position, using water bed. These patients are bedridden, so chance of developing deep vein thrombosis and consequently pulmonary embolism is quite high. So you may give low molecular weight heparin, or we may use a thromboguard to prevent this kind of complication. This patient may have retention of urine or urinary incontinence, constipations, then it has to be taken care. Immunotherapy, the treatment of choice is IVIG in pediatric. In adult they may do plasmapheresis, and this efficacy is quite similar. So IVIG we usually give 2 gram per kg over a period of 2 to 5 days. Either you give 400 milligram per kg per day for 5 days, or you can give 1 gram per kg per day for 2 days. So IVIG is a drug of choice. Plasma exchange. What do you do in a plasma exchange? You take out the blood from the patients, okay, you remove his plasma and add a donor's plasma, and then just infuse in the patients again. So you are removing plasma. In this way what you are doing, you are removing the autoantibodies which are causing problem. So this is a principle of plasma exchange. So what the American Academy of Neurology says, if the patient is unambulatory, is not able to walk, then this is an indication of doing immunomodulatory therapy. Treatment of middle facial variant of GBS, usually they recover of its own, just you have to observe, and if there is a increase in weakness, then you can use plasma therapy or IVIG. Steroid is not indicated in case of GBS. There is trial going on of IVIG plus steroid, and they found that the IVIG plus steroid is effective and isolated steroid is not effective. So don't use steroid. Pain is very excruciating, so we have to use either gabapentin or carbamazepine, or you can use paracetamol or anti-inflammatory agents, NSAIDs, or tramadol or mexiletine. Rehabilitation is very important. Okay, so these patients are bedridden, they may be atrophy of muscle, developing of contractures. So early institution of physiotherapy, occupational therapy, speech therapy is very important. The range of motion exercise, increase in strength, so various kind of exercise has to be instituted as early as possible. Speech therapy, because there are difficulty in swallowing because of oromotor weakness, so speech therapy is very important for speech as well as swallowing. So what is the prognosis? So best case scenario is that the patient has a difficulty in weakness, there is difficulty in walking and recover over a period of few days. So this is a best case scenario. And worst case scenario means the patient present with a case of acute onset of weakness, and they goes on ventilator within few days or few hours, and there is incomplete recovery after 1.5 to 2 years, means there is no recovery. So this is the worst case scenario. Okay. So usually what happens, the patient present with weakness, they progress over a period of 2 weeks, then they plateau and then they recover. So approximately 80% of the patient with GBS walk independently at 6 months, and 60% patient attain full recovery of motor strength by 1 year. Okay, recovery in 5 to 10% of the patient is delayed over a period of several months. Okay, 2 to 12% of the patients may die. So this is the as prognosis of GBS is concerned. So we have seen that almost 80% of the patient may have normal outcome, and poor prognosticating factors are preceding onset of gastrointestinal infection, older age, poor upper extremity strength, and acute hospital stay more than 11 day, ICU requirement, need for mechanical ventilation, rapid progression of onset of weakness, and delayed time to peak disability. So these are the bad prognosticating signs. 10% of the patients may have relapse, but recurrence is quite rare, and recurrence may occur because of certain vaccination. So possibly you have to avoid vaccination till 1 year after the attack of GBS. So to summarize, the GBS is immune mediated polyradicular neuropathy. There is a various type we have seen, and it may cause respiratory failure requiring ventilation for 25% of the patient, death in 4 to 15%, persistent disability in 20%, and persistent fatigue in 67% of the patient. Diagnosis is usually clinical and with support of investigation. Early treatment is with IVIG or plasmapheresis, and rehabilitation is very important as far as the long-term outcome is concerned, and it is also associated with significant morbidity and mortality. Now we have seen the most common cause of acute flaccid paralysis is GBS. Now there's few other causes, and we'll just have a brief discussion on these causes. The next is a traumatic neuritis. So when there is a history of intramuscular injection in buttock, actually you have to give in upper lateral quadrant. So but if you give wrongly, then it may affect the sciatic nerve, and it may cause the traumatic neuritis. So usually the patient has motor as well as sensory symptoms, and there may be pain and hypothermia affected. So you have to differentiate this from polio, because polio also has affection of one limb, and traumatic neuritis may have affection of one limb, and polio may be precipitated by intramuscular injection in 40 to 50% of the patient. So how to differentiate? The polio is pure motor weakness, while in traumatic neuritis there is a sensory affection and pain. Okay, and when you do CSF examination, the poliomyelitis has pleocytosis, while traumatic neuritis will not have this thing, and their management of traumatic neuritis is supportive. Now diphtheric neuropathy. So diphtheria is now rare, but it is again there is a resurgence of diphtheria because of weaning of the immunity as the age progress. So post diphtheria, because of the neurotoxin, there may be neuropathy, demyelinating neuropathy 3 to 5 weeks after diphtheria. So it may start with bulbar weakness and then may affect the other limb weakness. Other causes of acute flaccid paralysis is acute intermittent porphyria. So this present with a triad of abdominal pain, psychiatric symptoms, and peripheral neuropathy, and urine will show porphyrobilinogen. So how to approach a case of child with acute flaccid paralysis? So we'll come back with the case which we have discussed at the onset of talk, that the child of 3-year-old child present with a history of acute onset of weakness affecting lower limb, then over a period of 2 days affected the upper limb, then there is a decrease, there is a problem in swallowing and change in voice and nasal regurgitation. So if there is a flaccid paralysis and there is a sensory level with early affection of bowel and bladder, then we have seen that if there is a sensory level and bowel and bladder involvement, then it is a spinal cord involvement. So it may be transversemyelitis or compressive neuropathy or traumatic myelopathy. Okay, so transversemyelitis, compressive myelopathy, or traumatic myelopathy. If there is a flaccid febrile symmetric para or quadriparesis with bulbar respiratory involvement, with areflexia, with sensory symptoms like pain, paresthesia, then the cause is polyradicular neuropathy, and the most common cause is GBS. If there is a flaccid, febrile, pure motor, asymmetric paralysis with no bladder involvement with meningismus, then it is most probably either enterovirus, poliovirus or vaccine associated poliomyelitis. If there is a flaccid motory sensory lower limb monoparesis after IM injection, then it is a injection neuritis. If there is a ophthalmoplegia, ptosis, bulbar weakness, motor weakness, ataxia, so it is a myelofascial variant of GBS or botulinum toxin or myasthenia gravis. If there is a proximal muscle weakness, muscle tenderness without sensory symptoms and sign with preserved reflexes, then it indicates viral myositis or inflammatory myopathy like dermatomyositis. So as far as investigation is concerned, you have to do MRI brain, so it will show whether there is a transverse myelitis or compressive myelopathy, or there is some infection, or there is an infarct on the spinal cord. As far as the GBS is concerned, there would be enhancement of anterior nerve root. X-ray spine has to be done to see whether there is an atlantoaxial dislocation or there is a vertebral tuberculosis, spot spine. Electrophysiological study like nerve conduction study and electromyography is very essential for diagnosis of Ghia syndrome, but it may be normal in first week. Lumbar puncture is very important. If there is a albuminocytological dissociation, then it is GBS. If there is a pleocytosis, then it's a viral myelitis. Biochemistry like CPK, it will be eliminated in a case of myositis. Potassium, sometimes hypokalemia, hypokalemic periodic paralysis may present with acute flaccid paralysis. So it's very important to do potassium level. Hypermagnesemia may cause weakness. ECG, if there is a hypokalemia, then you will say the typical ECG sign of hypokalemia. And urine for porphobilinogen in case of porphyria. Now, to summarize the management for Ghia syndrome, you have to give IVIG 2 gram per kg over a period of 2 to 5 days. If there is a transverse myelitis, then you have to treat with steroid, methylprednisolone, IV methylprednisolone. You have to give 30 gram per kg per day for 3 to 5 days, and then oral steroid 2 mg per kg per day for 2 weeks and taper over a period of 2 to 3 weeks. For compressive myelopathy, then you have to do either spinal immobilization, surgery and steroid. For dermatomyositis and myasthenia, you have immune modulatory therapy. And for hypokalemia, you have a potassium. So friends, we have seen in last few 45 to 1 hour we have discussed what do you mean by acute flaccid paralysis. Means acute onset of weakness, there is a areflexia, there is hypotonia, and there is a maybe affection of respiratory muscle or oropharyngeal muscles. So these patients are very important first for community purpose, that you have to rule out polio. So you have to call the AFP surveillance officer. They will come and collect a stool sample, okay, and then this patient has to be monitored because there is a rapid progression of weakness and they may require ventilatory support. So we have to come to the diagnosis on the clinical basis with the help of investigation, and if you come to the diagnosis, then you treat appropriately. Okay, so I hope you understood and you will not be afraid of treating these patients of acute flaccid paralysis. Have a wonderful day. Thank for your kind attention, and I hope you are doing good in this COVID scenario, because this COVID scenario is a very traumatic mentally as well as physically. Okay, so we have to maintain our health, mental as well as physical, in COVID pandemic. So I will recommend you that you should do a good 30-minute exercise every day. You have to do yoga, pranayam, meditation, eat good healthy vegetarian food, don't eat outside food, don't eat too much of sugar. Okay, if you have some stress, then you share with your friends. You can do video call, you can write down your any stress problem in a diary. If you are feeling anxious, depressed, take the help of your friends or your family members or doctors. And mind you, I would like to share one story about this corona pandemic. Once there was a king. He asked one of all his wise men, tell me one word which I will use when I am happy or I am sad, when I am victorious and I am defeated. I can use this word at any moment. So the wise man puzzled, so what is this word he can use at any moment? But there was one old wise man, he write down one sentence on a piece of paper and hand over to the king and say, read this mantra, read this sentence when you are in a dire emergency. So the king put this cheat and put in his diamond ring. After a few months, the opponent king attacked this king, and this king and the soldiers fought bravely, but unfortunately this king got defeated and he has to run in the jungle. The opponent soldiers were following this king and he was on his horse. He reached to one spot and he stopped there. There was a deep valley and the opponent soldiers were following him. He said, it is the end of the world. He just closed his eye and then he remembered the fact that the old man has said you have to use that one sentence when he is in dire emergency. So he removed the cheat from his diamond ring and read. So what the word was written, what the sentence was written? The sentence was, this too shall pass. Okay, तो ये भी जो difficult situation ये निकल जाएगा. So he gathered the courage after reading this sentence, and fortunately the opponent soldiers moves away. So this king remained in the jungle, then he reorganized his army and after a few months fought back and defeated his opponent king. Okay, so when he was entering in his kingdom, all the people were very happy. They were showering the flower on him. So he was become very egoistic and said, I have defeated this king, and he was elated. But again he remembered the fact that these too shall pass. Okay, so he remembered that when I was victorious, that phase passed. When I was defeated, that phase passed. So my dear friends, there would be moment in our life where we will feel very depressed, anxious, but remember the fact, these too shall pass. This corona pandemic will pass over a period of few months. We have to just maintain our health, physical as well as mental, and I have discussed with you how to maintain your health. So do good exercise, have a nice 7 to 8 hours of sleep, had good food, eat good food, do yoga, pranayama, meditation. Okay, write down your worries on diary, talk to your friend, have a social support, and have a hope. Okay, and we as a human being has faced this kind of pandemic, and we have overcome, and we will overcome this pandemic of COVID. Okay, with this note, this is Dr. Sunil Sable signing off for now. Take very good care of yourself and have a wonderful day. Thank you.